Dr. Natasha Pahuja, who's the Chief of the Cornea and Refractive Department at Natasha Eye Care, based at Pune, and she's going to talk to us a very important topic and quite complex. How do I do topo-guided planning in irregular corneas? On to you, Dr. Natasha. I think, are you unmuted?
Can you hear me?
Yeah, we can.
Okay.
Not see your slide though.
One second. At the outset, I would like to thank Chitra ma'am and the ARC committee for giving me this extremely humbling opportunity. Dr. Jitin has made my job so much easier, and I'm just going to take a leap forward and look at what the irregular corneas can do. Now, what are we essentially looking at when we're doing topo-guided corrections? Is if this is an irregular cornea, we are basically recontouring the surface. Now, the patients that are coming to us are getting demanding by the day. Be it a keratoconus patient or a post-refractive surgery patient, they come to us asking, "Aapke paas contura hai kya?" So basically, contura is synonym to topo-guided ablation. But how do we apply it in irregular corneas, and who are the ideal candidates? Now, the irregular corneas specifically are a gamut of patients that can come to us. Most importantly, we're going to look at the most common presentations, which is zone enlargement or a decentered ablation, keratoconus patients, and of course, post-LASIK ectasia. Now, what do we essentially look for when we're looking at a topo-guided ablation? Patients who are ideal for it are patients who do not have a good contact lens fit, are looking for better quality of vision, have got enough pachymetry to spare, and most importantly, are of the right age. But the most important aspect of a topo-guided ablation is that the patients should have extremely realistic expectations. And they have to understand that they may need glasses after the laser ablation as well. So what are we basically looking at? In the next 8 minutes, we're going to justify, is this possible for irregular corneas like this? So the machines that are available that can provide a topo-guided ablation are such. I'm going to concentrate on two machines, which is Wavelight and Schwinn-Damiris. Starting with the Schwinn-Damiris, what essentially is topo-guided ablation is just very simply, as has been mentioned by Dr. Goel, is normalization or neutralization or smoothing. You can call it anything that you want. Basically, we are recontouring the surface to make it slightly more smoother. How does this work? Now, let's take it step by step. And how do I do it? There are very simple things. The things that we need is one, a refraction, a topography, pachymetry. These are absolute essentials when you're planning a topo-guided treatment for an irregular cornea. And let's see how do we plan this and the applications. Refraction, most important is a subjective acceptance. Like Dr. Goel said, you have to refract these patients yourself. What I essentially do is I ask two of my other optometrists, senior optometrists, to also do the refraction and we verify our results amongst each other before the patient is taken up for refractive correction. Most importantly, I also compare with the refraction that I get from the topography machine as well. This basically comes from the ray tracing method. So it measures the wavefront aberrations and gives us a refraction. So it is a good idea to compare the subjective acceptance with the topography refraction. What Schwinn-Damiris or the Schwinn-Cirrus also does is it gives you a small option of putting in the subjective acceptance and comparing with what the machine gives us. Coming to topography, it's absolutely essential to get the right scan. Now, this is a format that we usually get, and this is what we get. But most importantly, the acquisition quality is what needs to be checked before the topography is accepted for ablation. Now, I do the topography myself if the patient is taking up for surgery. What I essentially do is the red cross has to coincide with the Purkinje image. That means the surface topography has been taken correctly. Most importantly, I also look at the Myers. The Myers don't have to be distorted owing to the tear film. The distortion can come from the irregular cornea, but not because of the tear film. I also look at the statistics of how much is the coverage of the placido ring. Is the right amount of data taken up for the refractive correction or the topo-guided correction. Third and the most important aspect is the pachymetry and calculating the residual stromal thickness. Now, if it is a biomechanically weaker cornea, I would keep the RST as to 400. But if it is a normal cornea, like a post-LASIK, which is having a zone enlargement, we can go up to, we can have an RST of more than 300. Depending on the pachymetry that we have, we can decide as to how much amount of sphere or cylindrical correction can be done. Most importantly, a biomechanical weaker cornea has to be enhanced with cross-linking. Now coming to the treatment planning. I'm going to take two cases and which is going to probably summarize the whole treatment planning itself. Case one is a post-PRK patient who had HSV keratitis 12 years back, has got a scar which is causing flattening in the superior nasal quadrant, and of course a keratoconus patient. Now a patient who had topography like this, patient specifically came, who has not been wearing glasses, came with glare and distortion of vision and has decreased vision. The subjective acceptance is such, topography acceptance is the cylindrical acceptance, that means matching the topo refraction. Also the thinnest pachy is 520, so I have enough pachy to do the topo-guided ablation. I did it on the Schwind Amiris. I went to the ORK cam. This is where the corneal wavefront correction happens. So what I essentially do is put the manifest refraction as 0 and look at the ablation profile. Now you have to do it in the PRK mode, because if you do the trans PRK mode, then the ablation profile is just red all over and you do not see the subtle changes that can be picked up in an ablation profile. After that, the treatment is obviously done in the trans PRK profile. Now this is the ablation profile that we got. Now if you look at the ablation profile, we say a maximum ablation of 77. That is quite a lot, but the cornea and the biomechanics was good, so we went ahead and just did the 0 refraction. And if you look at this, it compensates really well. It is a very good contouring that is happening. So this is what we went ahead with. What was very, very encouraging was that the patient came back with a topography which looked like what the patient had before the scar. So it is a very good post-operative case that we example that suggests that not only the unaided vision improves, but also with a small refractive correction, the aided vision can also improve. Coming to the next case, which is the keratoconus case, which is the most common application of topo-guided correction. Now, this is a patient who had a subjective refraction of a minus 3.5 cylinder, but a topo refraction was almost up to minus 6. But I do not have enough pachymetry to obviously correct all of it. So, I went ahead and looked at how much is the total ablation, which went up to the magnitude of 65. Now, of course, after removing the epithelium and doing cross-linking, 65 was sounding a little too much. And this is how the profile looked like. So in this case, I went ahead and did what Professor Shetty has published, which is called as a TREC, as topo-guided removal of epithelium, but it also knocks off the cone a little bit. Now let's see how is this newer application coming into being and how do we plan it. Now we basically take the short axis and measure the long axis, and we see where is the intersection point. Now this intersection point, all these data is measured and it is simply put in the PTK cam mode. Now what we do essentially in the PTK cam mode is the long axis, what we have measured is put here along with the axis, along with the short axis, the automatic axis, the opposite axis comes automatically, and the radius of offset, that is the star mark that we mentioned, that is basically the intersection of both the axes. Now essentially we have to make sure that the trans PTK mode is off and the pachymetry or the ablation that we do is 70 microns. Now this is how the small ablation looks like. So instead of us having a 67 or ablation, the final ablation that we get is 71, which is including the epithelium. So the epithelium that we measured on the pachymetry, on the epithelial mapping was 50. So essentially what we are ablating is just 21 microns as opposed to 65 microns in the topo-guided ablation. So this is what the complete ablation profile looks like. It completely knocks off the cone and makes the cornea slightly more smoother. Now this is a validation of what I was just trying to explain. So the pre-op topography, which is showing a steep cornea, has flattened after TREC, and which was very, very encouraging in terms of the outcome in terms of the visual outcome of the patient. So the uncorrected visual acuity of this patient had improved to 6.9. This is another example where the comparative map shows that there has been almost 6 diopters of flattening with just 30 microns of knocking off. Most importantly, we also looked at the sagittal maps. The sagittal maps, the ablation looks much like how a topography guided ablation or a topo guided ablation, what an Alcon would or Wavelight would do. This is done by TREC. So what I'm essentially trying to say is that this is also a very good tissue sparing topo guided ablation, essentially removal of epithelium, but it knocks off some amount of stroma as well, making the cornea slightly more regular. Coming to the Wavelight, we have published this paper. It was called the Q protocol. And this is a very simple protocol. It is based on the corneal sphericity. Now, if we have a Q which is more than -1, along with the C4, C12 compensation that has been already explained, if the Q is more than -1, the Q is not changed. Sorry, if the Q is less than -1, the Q is not changed. If it is more than -1, it is changed to a slightly more bearable Q, if I could put it that way. And of course, based on the pachymetry that we have, we correct the amount of sphere based on the residual stromal thickness that we get essentially. So what I'm trying to essentially say by this is that by a topography guided, even with zero refraction, we can get very encouraging results. And of course, these patients have to be subjected to a contact lens or a glass prescription post cross-linking. So the question to summarize is it really possible for regular cornea's vision like this? It is possible, of course, with adjuvant methods like glasses or contact lenses after. Thank you very much for your kind attention.
Thanks a lot, Natasha. That was a very useful information which you did give us. But with the 458 cornea, of course, we do not have Schwinn. We would have confidently gone ahead and done a topo-guided regularization because we still have enough tissue to remove. Now, supposing you are stuck, you had 458 corneal thickness. Supposing you are stuck with a 435 or a 440 and you don't have facility to do TREC and you don't have access to Schwinn. So I have understood, I would want my expert panel to correct me whenever. What I have understood is I can actually bring down my optic zone from 6 millimeters to 5.5 millimeter, which would guzzle up less tissue. The other thing we can do is we can add a little bit of hyperopic correction in our refraction. That again, when you enter it, you realize that little less of the tissue is being guzzled up, but at the same time, topographic regularization is done. But I do understand that TREC is another beautiful way wherein you've just removed 20-25 micron and you have still gone ahead and regularized the cornea. But here, no, by doing a topo-guided regularization on our the Alcon platform, we are able to do some amount of refractive correction too, and then give them a better quality of vision. Dr. Gaurav, Dr. Ramurthy, anybody Dr. Tityal, any of you are using these machines, have any thoughts to add?
So even I wanted to ask Natasha the same thing. If you don't have a Schwinn machine, I mean, I'm sure TREC is not possible on other machines. So yeah. What would be your take on it? And have you compared doing TREC vis-a-vis doing on the Schwinn machine with other machines also?
So, ma'am, I have done one eye Schwinn and one eye, basically a topo-guided, a corneal wavefront, which is akin to a topo-guided correction of Wavelight. So, a corneal wavefront correction on Schwinn, which had enough pachy to spare, which was 470. I did a topo-guided correction and in one eye and did a TREC in the other eye, which had a pachymetry of 440. Quite honestly, ma'am, the results are almost the same. But of course, the eye which had 440 pachymetry was already an advanced cone. So in terms of, if you ask me in terms of visual acuity, they're not comparable. But just aesthetically looking at the topography correction is quite encouraging.
Dr. Gaurav, you want to add something?
Yes, ma'am, I think basically TREC, how it is different from what topography guided on Alcon platform is that it works on a very small decentered zone. So TREC is basically trying to just flatten the kind of cone a little bit. That's why you get away with just doing about 10, 15, 20 microns because you're not really addressing the whole topography and you're decentering it to just kind of fire on the cone itself. Whereas a full topographic ablation, as happens on the Alcon platform, is that it's also trying to kind of raise some areas and like right, press the cone and kind of making it the cornea more. So the optical zone on a topography guided treatment is much bigger. Whereas on TREC, you are essentially doing a very small zone decentered ablation to kind of flatten the cone a little bit. And that's, I think, when you are really short of tissue, that's probably the better way to do it, because you are not going to be able to do much. You probably won't be able to treat them on the topoguided Alcon platform at all. You won't have enough tissue.
No, but on an Alcon platform, sometimes you enter it as zero refraction and you regularize it. Then if you see that the tissue consumption is less, I still feel that I would opt for that as against TREC, and I would look TREC for even thinner corneas when I can't do a topographic regularization, and would I do just a CXL or TREC? Then I think TREC has a role to play in that. Would you agree on that score, Natasha?
Absolutely, ma'am.
Yeah.
Depending on, well, of course, the more advanced the cases go, you would hold yourself back from ablating the cornea.
Yeah.
But like you rightly said, if there's enough pachymetry, you would choose TREC over topoguided in advanced cases.
Yeah. So anybody to add? Shall we go on to our third speaker? There are a whole lot of talks ahead. We have with us